So again, we're talking about traumatic lesions around the hip.
Yeah, so I see edema in the muscle immediately anterior to the hip. I'm wondering if this is a psoas right here.
Through here.
Do we have any axials?
I don't think we have any.
Okay, because on the last image on the left, that almost looks like that's maybe kind of torn tendon.
Here?
Yeah, like if I don't know if it's attached or not. It looks like it might, because there's quite a bit of fluid, so it's at least a partial tear. I think this is a psoas going down to the lesser trochanter.
Yeah, this is a distal psoas.
Yeah.
Okay. Ashu, what do you think of this one?
Looks like there's a lot of edema within the psoas musculature here. You know, I'd like to see the attachment, but it looks like there's just a lot of edema there, and the fibers look like there might be a partial tear as well.
Well,
or just strain.
Well, so what would you call this? If the sportsmedicine.com sub says what grade is it, what would you give them?
Given that there's some, like on the axial, it looks like there's maybe some fluid collections. Maybe it's between a grade 1 and grade 2.
Well, I think this is a pretty classic grade 1.
Okay.
The fibers are nicely intact. You don't see any focal fluid collections, and the edema is just along fiber tracks. I think this would be a grade 1.
You don't see any fibers that are torn, do you?
Just the edema along the fiber tracks, right?
That's all I see. So interstitial edema from a strain, grade 1, if you want to call it, if you want to grade it.
68-year-old female with severe pain radiating to the knee. Again, it looks like we're in the region of the iliopsoas, and there's at least some partial tearing. Here I can't see any intact fibers, so I'm leaning towards grade 3, but I'd evaluate further. Here it looks like there may be some intact fibers, so probably at least a high-grade partial thickness tear or a high-grade grade 2 injury. And there's some surrounding hemorrhage and intramuscular edema.
This was a
grade 3. You said that there are intact fibers?
No, actually looking down further, it looked like they were completely absent on that that image. We don't see any fibers, so it's a grade 3.
I think I don't see any. It is totally white there. So I think that's a complete tear without retraction. So there's a surgical consideration here, obviously.
Okay, 77 male with pain for 1 week after hearing a popping sound. So there's quite a bit of edema along the myotendinous junction of the psoas, and it looks distally. I'm not sure if there's any. I don't know if it's just the cut or if there's. It doesn't look like there's intact tendon. And here it looks like we have fluid where tendon should be. So it looks like it's going to full thickness tear with distal retraction and strain involving the myotendinous junction as well.
Shoot.
I want to know where you're getting these cases from, John.
Just from everyday work.
That's pretty unusual stuff.
So we have a 19-year-old male with right hip pain, rotation abduction. Oh.
Yeah, just a second here. Okay, go ahead. I'm sorry.
Looks like there's some increased edema within the Psoas there, and there's some fluid near the myotendon. The attachment looks, and distally the tendon looks okay. So it looks like there's focal edema there anteriorly.
So I'm showing different appearances here of iliopsoas disease. Now, so this one has right hip pain with rotation and abduction. And we can see the edema right in through here. And then here you can see the edema right along where the tendon's coming at the myotendinous junction.
Is this like a snapping, internal snapping iliopsoas tendon pathology?
And the person feels a snapping when they move their leg. This is what's called snapping iliopsoas syndrome. And it's just showing a little bit of edema right where it's irritating it. It's also called coxosaltans iliopsoas tendonitis, and it's also called dancer's hip. Different names for it.
That's actually not uncommon in my experience.
Yeah.
So especially somebody who's really overdoing it a little bit.
Good.
We have a 16-year-old female soccer player with history of snapping psoas. Here again, we can see that mild intramuscular edema along that iliopsoas. This could be seen with snapping hip syndrome. I don't see a tear.
Another example. And I think here we can still see the edema around the iliopsoas muscle there, that tendon. And through here as well. And right in here. It just shows where the snapping occurs.
When they kick that ball, it's like a pitcher throwing that ball. But probably if you're close by it, it can hurt.
Okay, so on the left hip, we have like a large amount of edema, actually kind of fluid collection within the iliopsoas myotendinous junction. It actually looks like it's intramuscular, so I wouldn't call it bursal effusion. I don't know if there's at least partial tear with cyst formation.
This follows right down one tendon.
Okay.
Patient also has ATM.
Oh yeah. So the left hip's also markedly abnormal.
Typically, fluid when you get what's called Iliopsoas bursitis, which again almost always is a traumatic etiology, like we've talked about a lot of the other bursitises. And here's other examples of fluid collecting, normal side, symptomatic side, where you can see the fluid collection along the iliopsoas there. Acute.
So a 19-year-old male, sudden onset groin pain, looking along the left hip near the iliopsoas insertion. You see a lot of heterogeneous signal. It could be a hematoma within the bursa as well. A lot of muscular edema also.
Yep.
Is that with the adductors? Oh, okay, so it's just calcification.
Well,
Okay.
it's called myositis again. It was referred to a tumor surgery. And here's a scan 2 weeks later.
It looks like quite a bit of resolution. I think it was just a resolving hematoma.
And then going back to history, the patient fell basically skateboarding, going downhill. Now we've got a big hematoma. But actually what this patient was doing is the following. Here we can see. So that's not a good thing to do.
So, I guess that who read it initially thought the hemosiderin was calcium?
Yes.
Okay.
Yeah, that's what they're concerned about. And that,
I don't think it was worth it.
I don't either, John. Okay. Okay. So the patient was then brought back for MRA.
All right.
I'm sorry. How about the pulses? Were they okay?
I don't know, but they brought him back for an MR arteriogram. So my assumption is that they weren't.
They were not. They were not a very old folks on those skates. Well, okay, I guess they were worried about laceration.
What do you think, Andrew?
I think, is this the circumflex going around? Is there an aneurysm there on the left side?
Well,
yes. I thought it was, oh, I was looking at the bottom picture. I thought there was a saccular aneurysm extending there.
Here?
Yeah.
Oh,
It looks like it's leaking. Yeah, you can see the aneurysm. And did they coil it? It doesn't look like it's,
so they
there's
have,
any distal.
so they have an occluded artery there. So we can see that location. So this patient had a big vascular lesion right where they had that hematoma. Good.
I don't think anything is to be done for that other than tie it off if you have to.
I don't know.
That's probably what I would recommend if I was the surgeon.
Is there an increased risk of osteonecrosis because of that?
I don't know.
Not from that vessel, no.
All right, so here we have some images through the bilateral greater trochanters, and there's some increased signal and marrow edema along that left greater trochanter, probably near the medius attachment. So this looks like a high grade to complete tear. There's some preferential fatty atrophy of the gluteus medius, and some bursitis.
So as you call this trochanteric bursitis, as you know, but these are really tears of the tendon insertions there. And this is another really old example of what we used to call trochanteric bursitis, with fluid collecting in the bursa there.
Okay. Female right thigh swelling, pedestrian, was TA for a month ago. Traffic accident. So she's got comminuted fractures of her pubic rami bilaterally. So ultrasound, assume of the pelvis. So there's kind of heterogeneous fluid collection with internal debris, which I'm guessing is a large hematoma. I guess that's on the side of the thigh. And so we see this large fluid collection kind of on the kind of somewhat deeper fascial layer with heterogeneous signal within it. So this is concerning for like the internal shear injury, like a Morel-Lavallée lesion.
And there are different grades of these, which I've never really talked about in a clinical setting. So, but I think
I think we talked about treatment, haven't we, John?
why don't you talk about treatment, John?
What you do is you make a small incision on proximal and distal, and then use a bottle scrubber to scrub the area and roughen up the surface of the tissue, and then put a
Compression.
Drain in it, and drain it, and bandage it real well, and you wait until it heals after you of course don't keep the drain in forever. You keep it in for a couple of days until the fluid stops draining. The fat in it fluid. The fat is one of the problems because they will not allow the tissue to heal together. Fat is sits around for a long time. That's the longest lasting tissue that we have in the body. Without circulation, it stays alive for 24, 48 hours. So,
5 days.
So then you have to get rid of it and then wait for it to heal. And these are not something like a subcutaneous hematoma. This is a lot worse.
Yep.
Fortunately, they're not that common.
Ashley, what do you think of this one?
48-year-old male with hip pain and mass after trauma. You can see a lot of edema. I don't know. It looks like I think it's external to the musculature. It might be within the musculature. I think this might be a large heterogeneous. This could be another Morel-Lavallée lesion along the thigh, the lateral thigh here.
This is a little bit more chronic. A lot of different components to it.
Same treatment.
Yep. And the different grades. And this just shows that it's really at the deep fascia, and it separates the subcutaneous fat from the deep fascia. And as John was saying, because the fat is involved with this, it's often very difficult to get the deep part of the subcutaneous fat to adhere back to the deep fascia, so it keeps just collecting and a problem. Good.
The 20-year-old that slipped on the ice. It looks like there's increased signal and hemorrhage along the anterior aspect of the gluteus maximus. And here we can see what looks like an intramuscular hematoma within the gluteus maximus, and there's some partial thickness tearing of the musculotendinous junction.
Did you say partial?
Yes, I think some of the fibers are still intact. It's a large muscle, the IT band. Okay.
So it's primarily a tear of the IT band, but there's probably
That's one area where the inferior arrows are. That looks like a complete tear, doesn't it, John?
Right. Yeah. Okay.
Okay. So there's a lot of edema and fluid tracking along that left. It was a posterior thigh, like in the hamstring, I believe. Yeah. So there's quite a bit of edema involving the semimembranous, semitendinous muscles on the left. So I'm of concern for a hamstring tear, but the biceps femoris looks okay. The biceps femoris, I think, is okay.
Why do you say that?
No, never mind. It's just involving the entire hamstring.
Well, I think that the biceps is kind of the lateral side here, and I think you're getting into the quadrant.
What are they going to do with it?
So I think the biceps is torn here.
I mean, if the ischial attachment is still intact, I assume you just rest on this.
Put a bulky bandage on and try to control the bleeding and let it heal. There's no way to suture that together that I know of.
Right. So, and then down through this area also you have the sciatic nerve, which we're seeing here, right along through there. On the axial plane, the sciatic nerve is right in through here, and it goes right by the origin of the hamstrings here from the inferior pubic ramus. So when you get injuries in this area, it's good to go up and see the nerve roots and follow them down into the sciatic nerve, and make sure that the sciatic nerve is not directly involved. Or if it is, let them know. So we can see there's a lot of fluid here right around that sciatic nerve. There's the nerve coming down. Okay. Ashu.
I think we're seeing a defect. Looks like there's a lot of fluid. There's bilateral hip replacements, but there's a lot of fluid along the right side, kind of adjacent and extending through near the gluteus musculature. And is it multiseptated somewhat?
Okay, so this is a large periarticular fluid collection in someone who has a total hip and has a lot of pain on that side. What are you concerned about?
I guess could it be post-surgical? Could it be an abscess? It doesn't look like it.
The margin's nice and thin here. This was someone who had a failed right hip prosthesis and loosening of the hardware, and developed. You can get these large fluid collections due to the instability, the chronic instability and irritation of the tissues. So this is one sign that you've got to be very concerned that you're having a hardware failure when you see big fluid collections like this.
Okay.
Okay, so we have coronal image through the pelvis, and we can see there's a fluid collection kind of along the right lateral hip. Okay, so it looks more like fat then. So I guess this could be a lipoma. It could also be hemorrhage, acute hemorrhage. If they have recent trauma.
This was intramuscular
hematoma.
Okay, so kind of superior to the left hip, I see a small circumscribed fluid collection. I believe this is stir image. And now I still see some kind of similar region where that fluid collection is. And in that, I mean, you can get in that region, you can get things like paralabral cysts.
Okay, so if we look back here, maybe that's a paralabral cyst. So you want to go back and look at the labrum.
Mm-hmm.
The labrum looked pretty good here.
The labrum looked pretty good, okay.
It has to be in that area, so these are some other images.
I guess you could have like some injury to kind of the gluteus attachments along the iliac.
Gluteus. But the gluteus doesn't attach, that attaches to the humer, to the femur, right? So
there, I mean, there's proximal attachments.
What is this right here?
I mean, that's the iliac. That's the superior acetabulum.
Well, what is this called? It's the anterior iliac spine.
Uh-huh.
Okay.
That's
so
I guess. Then what comes off the anterior inferior is the rectus.
So So this is a tear of the straight head of the rectus. There's a straight head and a reflected head. And so the straight head attaches right here, iliac spine, as you can see there, and then there's a reflected head that attaches on the side here. So that's a straight head, and then there's a reflected head that comes around and attaches on the side over here, and that's where it attaches. So there are really two attachments of the rectus femoris here, and this is not a rare injury in sports, and you have to look at both of these in evaluating the surgeon. So here we can see this is a tear of the reflected head. Here we're not right at the front anymore, we're on the side, and we can see the fluid coming across here, and this was a partial tear of the reflected head. Okay, Ashu.
Kind of similar. This is a 25-year-old soccer player, labral tear. This doesn't look like a paralabral cyst. We're looking along the, I think, the lateral aspect or the posterior aspect.
No,
and you can see.
Here are the vessels here. There's
Okay.
pubis. So your
Okay.
This is the anterior inferior iliac spine here.
Iliac spine. Okay, so this is so again where the rectus comes up. It could be like a. It looks like there's at least strain, if not partial tearing.
Right. So
of this rectus.
Strain, and then here we're seeing a more. So this is really a grade 1 tear of the rectus femoris muscle, really right up to the tendon, right along the musculotendinous junction there, and we can see the edema coming down in through here. And so this was a partial tear of the indirect head of the tendon going around to the side insertion.
Okay, this is a 33-year-old male with pain for 3 months playing soccer, and there's an ossification or ossific fragment along that anterior inferior iliac spine. So I would be concerned about an osseous avulsion injury of the rectus femoris. Here I'm looking for the fragment. There it is. Okay, so there along the anterior inferior iliac spine, there's a small ossific fragment, and there's fluid signal and some displacement compatible with a mildly displaced osseous avulsion injury of the rectus femoris attachment. The direct head, yes.
Here's some more evidence.
Okay.
Here we can see another injury in that same anterior inferior iliac spine area. Okay.
I can't hear you very well, John.
Okay, so on the coronal, either STIR or PD image, we have a lot of kind of fluid, kind of in the similar region on the previous exam. So it looks like coming off the anterior iliac. And I'm wondering if that black is there, if that's actually cortex, like avulsion, or if that's tendon.
It's tendon.
So if that's tendon, it's it's completely torn and distally retracted. So full thickness tear of the rectus.
So both the direct and the reflected head, both distal retract.
That's fixable, and I think I would do that. I would fix it.
Yeah.
What age is this patient?
I don't remember. I would say probably 20s.
Yeah, that's going to continue to be a problem until with activity when he starts.
Yep.
Otherwise, he'll be disabled for quite a while.
Yeah, I think it's surgical too. I agree with you, John. Okay, Ashu.
13-year-old male with left hip pain, 5 days post sports injury. Along the left-sided, we're anterior again. Is this anterior inferior iliac spine? Looks like there's
a bunch of different looks here, so you can see a lot of different ways this injury can look.
Yeah, it looks like there's quite a bit of edema. Kind of, there's fluid. It's partial tearing there. Oh, it's an avulsion, non-displaced avulsion, well, partially displaced avulsion there. The rectus femoris, and you can see, it makes sense as a 13-year-old. There's some edema as well within the bone.
It's the younger patient where the bone is the weaker unit, and this is a bone avulsion. So this is one that's typically treated surgically. John?
If I trusted this kid, I'd probably just leave him alone, or I would consider actually putting him in a cast.
Okay.
With one leg in a cast, other leg out.
So here we have a 23-year-old with right hip and thigh pain for 1 year and popping during soccer. And there is some heterotopic ossification there along that right rectus femoris attachment. This could reflect a remote injury with heterotopic ossification. Yeah, remote avulsion fracture. And then here we do see that ossific fragment. There's almost some scar tissue. It looks like some fibrous scar tissue between where it avulsed from and the ossific fragment, but there's still some surrounding fluid and edema, so this is not stable.
29 female left inguinal pain for a week, aggravation from 1 day, good no trauma history. So on the left, I'm looking for like an avulsed fragment, but I don't, at least from here, I don't think I can see one. And now it looks like there's quite a bit of signal heterogeneity within the rectus muscle, and there's edema at the anterior inferior iliac spine. I think there's still some in, I don't know if there's any intact fibers.
Crutches.
And you can also get more distal injuries to the rectus femoris muscle as well. And here you can see where you can have tears within the muscle itself. They can be adjacent to the musculotendinous junction, which extends for a long distance, and the rectus femoris or just out in the muscle itself. And here's some other injuries around the rectus femoris origin where the tendon now is intact. This is primarily a musculotendinous junction injury. And then here we have a higher lesion.
IT band.
Yeah, more the IT band and Sartorius up here. Yeah. Okay, Ashu.
On the right side at the anterior, so 14-year-old male with right pelvic pain after a sports injury. There's focal edema at the anterior superior iliac spine. On the right side, kind of worried about an IT band or Sartorius injury. You can see, I don't think I see bony fragments, so it looks like just a tear. It doesn't look too retracted. High-grade partial tear probably. Okay, there's an avulsion fragment. Okay.
I think this turned out to be a little bony fragment.
Okay.
Okay, so we have an 18-year-old professional soccer player. Here again, we can see a non-displaced osseous avulsion injury of the Sartorius attachment at the anterior superior iliac spine. It may be chronic. There's a lot of edema, but it's not displaced. It's minimally displaced. And we can see the surrounding edema and marrow edema and minimally displaced avulsion injury.
Okay, so on the CT scan, we see a small, mildly displaced fragment coming off the anterior iliac bone. The superior iliac spine. So there's concern for an avulsion fracture. That's probably the Sartorius.
Ashu?
15-year-old male. Looks like there's some irregularity along the right anterior superior iliac region right there. Looks like an avulsion fracture. I don't know if it's acute or chronic. There seems to be some muscular edema.
Did you say superior?
Superior?
I think it's inferior, don't you?
Well, I think the inferior, well, I can put down here. Down this area, I think this is superior. Over here, we can see closing of the physis on the left side, which is normal, and this is an avulsion injury on the right side.
That's the apophysis, isn't it, John?
Yeah, this is the apophysis over here, and here you can see the apophysis is separated and avulsed here.
Yeah, it's a avulsion.
Yeah.
So, and with that much, that little amount of displacement, I don't think you'd want to operate on.
Okay, good.
I'm conservative when it comes to these kind of operations because one thing you don't need is an infection in an area that doesn't need surgery.
Good.
This is an 18-year-old freshman runner with thigh pain, rule out stress fracture. There is a small amount of fluid kind of along the medial aspect of the thigh near the vastus intermedius insertion, which could reflect some stress reaction. This could be like a tug lesion where it attaches there on the linea aspera, or chronic stress injury.
And these are called thigh splints. Like you can get shin splints, these are thigh splints, and these are partial tears of the muscle insertions along the medial side
there. He's getting his endorphins. He's lucky he hasn't fractured it.
Continual female leg pain for 1 month. Soccer player. So we see some kind of mild periosteal reaction, benign appearing periosteal reaction along the proximal femoral diaphysis. So consider for probably just like a chronic tug type lesion.
Why do you say mild?
Well, I guess by mild I mean it's more like benign, like it doesn't look like irregular.
Oh, you mean like we're not talking about tumors, so I don't think John would throw that at us. Okay. But that's not mild. That's a lot of tugging.
Mm-hmm. Yeah, now so on MRI we see.
And that's an incomplete stress fracture.
Yeah, this is one of the most obvious ones I've seen.
I think John will agree with me. I don't know.
Yeah, no, this is a pretty significant injury. I've never seen one this bad before.
This is pretty unusual too, because the kid is not in traction and getting surgery.
Yeah. Another name for this is the adductor insertion avulsion syndrome.
I think this is a stress reaction.
Yep.
Don't you, John?
I certainly do. Ashley, what do you think of this case?
19-year-old female with right thigh pain for 1 month after ballet. Along the medial aspect of the proximal femoral diaphysis, you see some periosteal reaction. It's a little bit irregular. I'd like to get an MRI to confirm that. CT, you can again see it's almost like there's some periosteal reaction and possible tug lesion there with increased edema on the MRI and the stir sequences at the adductor, and a lot of stress reaction in the bone. So again, adductor insertion avulsion syndrome.
Okay, why don't we stop here today, and we'll start up. I think it's inflammatory lesions of the hip that we'll start tomorrow. Okay, any questions?
Have a good evening, everybody. I heard